Good morning. Welcome to our Powerhouse Speaker Series. I'm Lily Litwin, President of St. Michael's Hospital Foundation. There is no doubt that COVID-19 has changed many aspects of our lives. As you know, it has had a particular huge impact on healthcare. In fact, it has pretty much turned it upside down. There are many vital lessons that we can learn from the pandemic. It has been the catalyst to reimagining Canada's healthcare experience. And thanks to the brilliant and relentless minds at St. Michael's Hospital, our leadership has recognized that it's time to redesign what hasn't been working in patient care and identify how we can do better. Thanks to each of you for joining us today and for your ongoing support that ensures our healthcare teams and our leadership can tackle some of the world's toughest health challenges. And improving the care experience is definitely one of them. And on that note, I'll turn things over to our host, Dr. Tim Rutledge, President and CEO of Unity Health Toronto. Thank you, Tim, and welcome.
Thank you very much, Lily, for the introduction. I am truly happy to be here today because we're about to do something very bold at St. Michael's, even audacious. We're going to look at the healthcare experience through a whole new lens. We're going to reimagine how the healthcare experience can provide comfort, connection, and confidence to every Canadian, no matter who they are or where they're from. Put simply, we're going to reinvent Canada's healthcare experience. We've learned a lot about the care experience over the past 6 months with COVID-19. We've learned about the power of delivering care in new ways. We know we're never going to go back to the way things were. But now the question for us is, how far can we go? How far can we take virtual care, for instance? Can we put virtual diagnostics right in people's homes? Can we have a digital doorway with an online concierge to make the hospital experience easier? How we use physical space in healthcare has also changed. How should we design hospitals to use space where it's needed most, like in patient rooms? We've learned that we need entirely new models for the most marginalized members of our community. We know that simulation is going to become even more important as medical students can't learn at the bedside as they once did. And we've certainly learned about the power of artificial intelligence. Imagine using artificial intelligence to absorb physicians' notes, test results, and medical science in seconds, so the doctors can optimize treatments right on the spot. Our first speaker today is Dr. Irfan Dalla, Vice President of Physician Quality and Director of the Care Experience Institute at Unity Health Toronto, and a physician in the Department of Medicine at St. Michael's Hospital. Dr. Dalla has a strong background in quality improvement in healthcare. From 2013 to 2019, he was the Vice President at Health Quality Ontario, where he strove to improve standards of care in the province, and he has won many awards for his groundbreaking work. He returned to Unity Health in January 2020. Our second speaker is Dr. Carolyn Snyder, Chief of Emergency Medicine at St. Michael's Hospital. Dr. Snyder was an emergency physician at St. Mike's before spending 7 years at Winnipeg's Health Sciences Centre, where she developed the Emergency Department Violence Intervention Program to break the cycle of violence in young people. In early 2019, Dr. Snyder returned to St. Michael's, where her work includes developing programs to serve disadvantaged populations, addressing root causes of violence in our community, and managing COVID-19 for people experiencing homelessness. And now I will turn things over to Dr. Seema Marwaha, who will be our moderator for today's discussion, as well as a presenter. Dr. Marwaha is an internal medicine physician at St. Michael's, who has a research focus on healthcare storytelling and patient experience education, including the use of virtual reality to better communicate experiences to learners. Seema has a master's degree in education from Harvard and has completed a fellowship in global journalism. She is also editor-in-chief of healthydebate.ca, that's healthydebate.ca, and is a regular contributor to media outlets like CBC and Chatelaine. So with that, over to you, Seema.
So thank you so much, Dr. Rutledge, and good morning to everyone. I love introductions. They always make me sound so impressive. I think we can all agree that the patient experience is in need of reinvention. Canadians certainly think so. In a 2018 survey about healthcare, more than 70% said the system needs either a complete rebuild or major repairs. Patient care and frontline stories about experience are really important to share, and our goal over the next hour is to highlight some important ones today. Dr. Dalla, Dr. Snyder, and I are going to take you through why we believe care experience, overlaid on top of science, research, education, and training, is both a necessary and critical mission for St. Michael's. I imagine that over the course of this time, you're going to have a lot of questions. So after we speak, we will open up the virtual floor to questions on the subject of patient experience. Here's how to submit your questions. Please look at the Q&A chat box on your screen. If you think of a question, some people have already used it already, for the speakers at any point, just type it in there and we will either pose it to the speakers in real time or hold it for discussion at the end of the event. We'll do our best to get to everyone, but if we don't have time, we will follow up with you via email. The chat feature has been disabled for this event. And at the end, there will be a few survey questions, and we would be very grateful if you would submit your answers before signing off. Today's webinar is also being recorded. We will share a link with you after the event, and we welcome you to revisit the content and share it widely with your colleagues. So that concludes some of just the housekeeping remarks, and it's time to get started. So I'm up first. Care experience is very close to my heart. It's a personal and career interest of mine, and I get to kick things off. One of the best parts of my job as a doctor / journalist / researcher is interviewing people about their experience. And here's one that has stuck with me. This is George. He lives in a rural community and his wife recently died of breast cancer. He was reflective about the experience when I interviewed him a few years ago. And he said, I quote, "The cancer clinic was sort of like an airport waiting room. Long lineups, extremely busy. It felt impersonal. I don't know how many times we told our story over and over and over again. We were told to wait and wait and wait for surgery, for appointments. I was so afraid she would get worse. I certainly wouldn't want to be negative, but from a user's point of view, it wasn't an easy process." This is unfortunately something I hear from the people that I've interviewed more than I'd like. But what surprised me about George is that he himself is a family doctor and had been for 35 years. He was the doctor in the town that he lived in. But in his own words, he had no idea what it was like on the other side of the gurney. If he had understood this, he told me, it would have not only transformed his care experience with his wife, it would have changed the way he interacted with thousands of patients. So then I wondered, was this just George? It turns out, no, this is not unique. It's actually common, and that most healthcare workers don't understand the experience of patients and families, but we think we do. We often equate our clinical experience with lived experience, and it is not the same. How do we know this? When we interview healthcare workers and doctors with personal illness experiences that are critical, 90% of them call it this aha moment, where they learned something precious during that experience that changed how they practiced and saw the system that they worked in. And they were more easily able to recognize things like dignity, fear, and vulnerability. And in a study of mine, when I interviewed patients and families, they see this plain as day. They say that providers often don't acknowledge their life outside the hospital. They have a lack of awareness sometimes, unintentionally, of suffering and vulnerability. And that we, in general, place an overemphasis on expertise and control in our training rather than empathy and relational skills. And providers often cite structural barriers as the reason to why we can't be empathetic. And while that might be true in some circumstances, as one patient put it to me in one of my interviews, quote, "We know you are busy and the system is complex, but that does not mean that you can't learn my name or make eye contact with me. Those things take no extra time." So how do our patients here at St. Michael's feel? Well, it's a mix. So this is a friend of mine, Becca, and her baby Theo. And Theo was born at 28 weeks and spent time here in the St. Michael's Hospital NICU. And these pictures are from just a few days before the COVID lockdown. In our interview, Becca describes being extremely grateful with her time here. She referenced very supportive staff who treated her almost like family. But when I read between the lines of her interview, I see challenges experience-wise. Wayfinding was difficult. Transfers were disorganized. It was sort of this organized chaos that she had to learn, adapt, and fit into to make it through. It wasn't the other way around. She said, quote, "The entire experience felt surreal, like a car crash or a movie. I had to tell my story repeatedly to everyone, different doctors and nurses. I could have been telling someone else's story. I remember feeling like Theo was a medical specimen because of the incubator and the other wires and machines. And I was just too scared to ask the question that I cared about. Was he going to make it? Because I wasn't ready for the answer." Becca's experience reminds me of this quote from a journalist at The Atlantic writing about being hospitalized as organized chaos. "I was terribly startled by the profound discomfort I felt in hospitals," this journalist writes. "The lighting was harsh, the food terrible, the rooms loud, a very busy apparatus of care with beeping monitors and hourly check-ins and forced wakings. In the hospital, I felt like Alice at the Mad Hatter's tea party. I had woken up in a world that seemed utterly logical to its inhabitants, but quite mad to me." COVID has made the environment even more confusing and challenging. And I think one example of this is the lack of family presence during COVID. So this is Abida, and she's pictured here with her son and caregiver Irfan. Abida is a long-term care resident and a dialysis patient here at St. Mike's. She was admitted to the hospital during the lockdown, and she started while she was here having trouble swallowing food and water. And Irfan was told by the doctors that she was going to die because of this and that she was palliative. And hearing this on the phone, he agreed to have his mom transferred to our palliative care unit, where he was finally able to come and see her. But he was surprised when he got there to see her condition. She was awake, alert, a little bit confused, but she doesn't speak English as her first language. And he took the risk and fed her some applesauce, coaching her in her language. He advocated to get her fed, got her put back on dialysis by advocating with the nephrologist. And just as she was getting better, he was told that he couldn't visit her anymore because no visitors were allowed during this time in the hospital. And he almost felt like he was punished for his advocacy. She's back in her nursing home now and doing well. And Fahad is grateful for the care he had with his mom. But he worries that coming from long-term care comes with a stigma and an assumption that those patients don't have quality of life. And he said this to me: "You can't look at the individual as just a problem to solve. When I talked to the doctors every day and relied on them to see her in my place, I would get the usually daily call talking about blood pressure and blood counts. They would lead with medical data that was meaningless to me. I'm not a physician. I have no idea. Every day my question back would be, how is she doing? Like as a person, but I don't think they assess for that," end quote. This is something that's been described by clinicians. Terrence Holt, a geriatrician, wrote, "Any patient in a hospital, when we take their clothes away and lay them in a single bed, starts to lose identity. After only a few days, they start to merge into a single passive body, distinguishable only by the illnesses that brought them there." We don't want patients to feel like this at St. Michael's, like a passive body defined by their illness. We want patients not only to get the best care, but to also feel cared for. Please join me in welcoming Dr. Irfan Dalla, our next speaker, who will speak more about this vision at Unity Health. I'm going to pass things over to Dr. Dalla.
Thank you, Dr. Marwaha, for those very powerful stories. Over the next couple of minutes, what I want to do is try to put everybody who's listening, and thanks for coming today, put you in the place of somebody who's actually going through care at our hospital. So if you'll indulge me, just close your eyes for a few seconds and think about the last time you were really ill. And if you're so fortunate that you've never been really sick in your life, think about a family member who is really sick. And I'm going to say a few words now that I think will resonate. Scared, vulnerable, powerless, confused, alone. Now keep your eyes closed for a few seconds longer and imagine that exact same illness. And imagine going through it, but now try to put yourself in the shoes of someone who doesn't have a place to live after they leave the hospital, or somebody who is Black, or somebody who is a newcomer to our country. And I'm going to say the same words again: scared, vulnerable, powerless, confused, alone. Okay, you can open your eyes now. Thank you. When Tim and I and others at St. Michael's started talking about me potentially coming back here full time, one of the first things I did was read the strategic plan. And I really, really loved the tagline, best care experiences created together. Every one of the 5 words in that tagline is vital. And I want to go through them one by one. So, best. We aren't aiming just to provide good care. That's the bare minimum. We want to make sure that the care that people receive at St. Michael's is not just the best in Canada, but the absolute best. Care, the second word. Sonia Kanzian, our Chief Nursing Officer and Executive Vice President, likes to say that one of the things that sets St. Michael's apart is that we don't just care for you here, we care about you. And that's exactly it. That is what I see on the internal medicine ward on the 14th floor, now spread across both Cardinal Carter and the Peter Gilligan Tower, every time I care for patients. The next word is experience. What exactly does that mean? So I love the move away from the word quality toward the word experience. And I say this as a quote unquote quality guy. You heard from Tim that I spent 6 years at a government agency called Health Quality Ontario. But quality is a technical word, and I think when it comes to healthcare, people don't necessarily grasp it intuitively. Experience is a word we can all relate to. We know what a good experience is. We know what a great experience is. Good experience in healthcare is one that is safe. But a great experience is one that isn't just safe. It's one where the care is centered around your needs, where you know that you can completely trust the people who are caring for you, where you know they don't just care for you, but they care about you. And for some of our patients at St. Michael's who experience various hardships in many aspects of their lives, a great experience is one where they can feel confident that they are getting care that is just as good as the care that our staff get, maybe even better than the care that our staff get or a board member would get. And finally, created together. In some ways, this is the most important part of the tagline. Patients and families working together with healthcare professionals create a great care experience. And great care experiences lead to great health. Everything we do needs to be done with that framing in mind. We, not me. Dr. Marwaha, Dr. Snyder, and I are going to take you through the last few months of the pandemic, focusing on the experience of some of our patients, some of our staff, and some of our physicians over the next 20 or 30 minutes. And as you hear their stories, I want you to keep thinking about this aspiration for the best care experience created together. And then at the end, I get to come back and take us all out of the pandemic for a few minutes and spend a little bit of time talking about our shared vision for the future. Thanks very much. Back to you, Seema.
Thanks so much, Dr. Dalla. Let's just take a minute to see if we have any questions on the chat. We do have one that was submitted earlier that I think might be answered well now. How are we managing the loss of volunteers and family essential partners on patient floors, and how did we manage that during part of this? I'll direct that towards you, Dr. Dalla.
Yeah, you know, I think there has been huge recognition during the pandemic that visitors aren't really just visitors, or a lot of visitors aren't really just visitors. And in fact, we've shifted the terminology, so we now call many visitors, family and close friends and loved ones, essential care partners. And there's been a recognition that, you know, somebody's spouse, their child, their loved one isn't just a visitor. You know, it's a little bit different than having somebody who, lives 8 houses down the street come to bring you flowers when you're in hospital, which is nice, but that's not what we're always talking about when we're talking about an essential care partner. And it's been really, really hard, as you know, somebody who provides care on our internal medicine ward, really hard for patients, really hard for their loved ones, and really hard for staff to see how alone, how vulnerable people are without the loved ones in their life. And over the last couple of months, most people probably know that visitors, essential care partners, have been allowed back into the hospital safely, carefully, wearing personal protective equipment after going through symptom screens. And really great that this is happening now. But we also know we have to be very careful because there is still the risk of COVID coming back into the hospital. And we also need to do everything we can to prevent an outbreak. So it's this balance between making sure that essential care partners are there so that patients can have the best care experience, but also making sure that that care experience is a safe experience. So thanks for that question.
Thank you very much. So that takes us to our next speaker, Dr. Carolyn Snyder. Dr. Snyder, COVID has profoundly impacted the ED, or the emergency department. And as chief of the emergency department, can you walk us through how COVID has impacted care experience, both for your staff and patients and yourself?
Thank you, Dr. Marwaha. I will never forget the evening of Saturday, January 25th. I received a call from Tim Rutledge that the first case of COVID in Toronto had been confirmed at another hospital. I was working in the Emerge that evening and met with all of the staff that were on. And early the next morning, Tim and I, along with other emergency department leadership, circled again through our emergency department to meet with the morning staff. Frankly, we were scared. All of us, the leadership, the staff, our patients, the city, the world, we were all scared. And I suspect that lingers for many. As emergency medicine people, we turned that fear into this sort of immediate action. We banded together and we wanted to ensure our own safety, our colleagues' safety, our patients' safety, and frankly, our city's safety. At St. Mike's, we were especially worried about the large number of patients who experience homelessness in our community. How would the city, how would the shelter system help those who are affected by homelessness if they too got sick? Indeed, this has become a major issue in the spring. Since March, we have cared for well over 1,000 homeless patients who are affected by COVID in some way. And frankly, this is already becoming a concern again this week with the second wave on our doorstep. The shelter system was already overcrowded and strained prior to COVID. Many people sleep in bunk beds well under 2 meters apart, often in very poorly ventilated rooms. And when homeless patients have COVID or are displaying symptoms of COVID or are close contacts of somebody with COVID, they too are required to isolate. And yet, this is almost impossible in most shelters in Toronto. So while we worked with the city to find isolation spaces, we at St. Michael's Hospital in the emergency department converted multiple spaces, our waiting room, small storage spaces, and all sorts of unconventional spaces in the hallways, not in the hallways, I should say, in areas just off the hallways that we would never have used for patient space, but we needed to set up isolation spaces for the many homeless patients who are waiting swab results or transport to the city-run isolation sites. And when we ran out of room, our colleagues on the inpatient wards had to admit them into the hospital despite not needing acute care. We hired extra community support workers, social workers, and nurses. And our addictions colleagues started providing around-the-clock support. We worked with family medicine to develop an inner-city rotation for family medicine residents who then worked with the social workers to then provide medical care to these patients, some who waited days in our Emerge. And through the support of the foundation, we had activities and extra meals and care patients to help keep these patients occupied. As the weeks went on, we saw improved swab technology, which helped decrease the time it took to get a result. And we also saw some isolation shelter spaces expanded in the city, although never to truly meet the full needs of our city. In early May, I had an especially memorable Saturday evening. Over approximately 1 hour, 20 people from one shelter arrived at our door. I was working a clinical shift that night, and all of them had been identified as close contacts of a client who had just been found to be positive for COVID. They may have slept in close proximity or eaten a meal inside with this person, and the staff at the shelter had just learned of this. So they were understandably scared, and they sent them straight to us. The problem that night is we already had 10 patients in our isolation spaces. Our emerge was full. The floor beds were full. And frankly, we'd run out of room. It was a major concern. The patients arrived around dinner time, and they were confused, and frankly, they were angry. They had been initially told that they just needed to get a swab, but it was clear to us that once they were identified as a close contact, they required 14 days of isolation, just as we would if we were identified as a close contact. But the isolation spaces were in a building across the city. There were many men that stick out in my mind, but especially two. One was a university student. He was enrolled in the spring session, but had fallen upon such financial hard times, as did so many during the COVID springtime, that he was unable to afford housing. He was staying at a shelter as a result, but he was worried about finishing his courses, as anyone would be. Another man who had a job in the gig economy. He was a driver of a delivery van, delivering the packages to us that we all ordered through the spring. For many of us, he was an essential worker. His partner was immunocompromised, and they had an infant at home in a studio apartment. So they had made the tough choice to have him move out to avoid potentially bringing COVID home to them. But now he was pretty sure that his job wasn't going to be there at the end of 14 days. He felt pretty scared, and he really had lost a lot of power. It was a hard night for us at St. Mike's. The entire emergency department staff worked closely with our inpatient teams, senior leadership, the city, Toronto Public Health, and the shelter teams to try and find safe spaces for all of these men to isolate. But it was understandably much tougher on the patients involved. And it was how we responded to their non-isolation needs in the midst of a fast-moving, difficult, complex evening that really highlights why I'm proud to work here at St. Michael's Hospital. These men weren't just people being shepherded through a system. Our ED team saw each one, making sure their medicines were up to date and that their medical care and needs were met, and that they had what they needed to stay in an isolation space, even if it was across the city. It included finding ways to address many complex care needs, mental health, addictions, but it also meant that they needed to be heard. We provided them with care packages to ensure their basic comfort. We answered their questions as to why this was happening. And we acknowledged that being scared, vulnerable, powerless, out of control, alone, and frankly, angry were valid. Totally understandable in the circumstances. And indeed, I too get angry at times when I think about the challenges that those who are experiencing homelessness have to face, and especially those who have had to face it during COVID. It fuels the work that I'm doing to try to improve the system that we in the emergency department are a part of. And reframing the way we provide care from the angle of understanding the journey of our most vulnerable patients in the emergency department has given me personally a pathway to work towards change and improvement in their own care experiences.
That's awesome. Thank you so much, Dr. Snyder, for taking us through those last few months in your department. I'm just scanning through the questions. There is one that is slightly related to what you're talking about that maybe I could ask you. So how are you going to disrupt the structures in the system that put reputational capital over patient safety that are ableist and racist? This was a question that was submitted before.
Thank you. And thank you for that question. This is a very important topic for me, or issue for me. I often share that my journey on understanding structural racism and the way my own implicit biases affect my care for patients started when I worked in Winnipeg. I was there during the inquest into Brian Sinclair's death, And for those that don't know this story, Mr. Sinclair was a middle-aged Indigenous man who died after 36 hours in the waiting room of the emergency department I worked at. I was also working closely with many community partners to develop an emergency department violence intervention program that Tim spoke about. And many of my colleagues from the community were Indigenous and truly became my teachers in this. I realized very quickly that this was going to be uncomfortable for me, but truly the only way I was going to learn about this and how I played a role in this. And the racist and classist and, as you noted, ableist structural inequities that exist and that many of my patients faced became very evident to me very quickly on a daily basis in my job. I learned and continue to learn about my own implicit biases and how to try to catch them and address them both in and outside of the emergency departments. And now, as a leader of an emergency department, I share my journey in this quite publicly, and I continue to do so because it's important for people in my department and people that I work with to know that it's an important process to go through, and it is rewarding to learn and understand so that we can make a difference. So as a department, we now have some newer protocols or procedures that we do. When we review a patient's case, we also look at what structural inequities they may have faced prior to coming in and during their experience in our emerge. And also what implicit biases we may have brought into that patient's care, or if we weren't involved ourselves, how we may have brought implicit biases in. And then we talk about how we may try to make change in that. The people that work with me need to develop this as a standard practice. It should be inherently a practice of all clinicians, but frankly, all people. And we need to go through an uncomfortable stage to get there. But only with that will we actually move forward to disrupting this in our place of work and in our city. I'm also extremely pleased to see that the work and the strategic direction of our corporate level has moved towards addressing this in many, many concrete ways.
Thank you so much. That was not an easy question, and you did a beautiful job answering it. I just want to take a quick 2 minutes now to transition. You spoke very eloquently about COVID and how it affected the emergency department. And, you know, as an inpatient physician, I saw how when those patients got admitted to the hospital, how it disrupted how we typically do things. And as an, you know, I was one of the first people as an inpatient doctor to sort of attend on the COVID ward in March. And I just wanted to take a moment to walk people through what that was like. So in March, a dedicated staff entrance was created at the hospital, and you had to screen either in person or digitally before you could enter the building. And screeners were put at every entrance. And this isn't typically, you know, what you think when you think of coming into St. Mike's. Visitors were not allowed, and restricted signs went up seemingly overnight. And so when I went to the ward that I typically work at every day, there was this stop, no visitors, which wasn't really the way that we sort of interacted in the past. Rounding actually happened not at the bedside, but in these back rooms huddled around computers and phones so that we could save PPE and limit interactions. We had to mask and we had to distance. As a constant reminder of impending PPE shortages, carts of equipment were under watch, and even now you still have to sign out when you need an N95 mask or face shield because we're worried about saving enough equipment for what's to come. And then many days I'd find myself actually peering through the frosted glass. So if you see in the bottom right, that's actually the door to a patient's room. And it's really hard to look through the glass because there's all these infection control signs that are there, just so that I could get a glimpse of what my patient looked like or what they were doing. I want to give you guys an idea of sort of what we kind of wear. So, you know, all the time when we're in the hospital, we have to wear these masks. And then when you're on the clinical ward, in addition, you have to wear a face shield. And so it's difficult to interact, even on this chat, actually, it's difficult to interact. You can't read people's lips. You can't see their expressions. And then with patients, there's just multiple layers, whether it's glass, gowns, masks, face shields. So it really does change the way that we communicate. And we wear these 24/7. We did our best to adapt, but one consistent thing that came up over and over again was the staff focus on care experience during this time. We were motivated to do what we could to help, but really powerless to sort of fix the problem. And so I want to share a few stories from a project that we were working on to try to catalog what the experiences were of staff during this time. Christina and Maria are nurses on 14, and when I interviewed them, they said, "We were here for SARS then and now. Our patients are isolated. They are locked away in their rooms. There's nobody to talk to except nurses and doctors for a few minutes every hour. They are alone. We give them phone lines, TV access, but it's not enough. They need the human touch, the family touch, and that can't be replaced." We know how critical family is to the care experience, and they're right, it can't be replaced. We interviewed Amanda, a resident who's working in the ICU, and she wrote, "I never saw her awake the entire time. She wasn't doing well. It was incredibly difficult for her daughter to know her mom was critically ill and not be able to see her, and I called her every day. But the toughest questions were the simplest. Had I ever seen anyone in her mom's state recover? Did intubated patients ever survive?" It's tough balancing not wanting to give false hope with not wanting to give false hopelessness. And then the last person I interviewed was Trina, who's a molecular lab technician. And she said, "I think when people say testing, they assume that a machine is doing the testing. They don't know, but it's actually a highly skilled professional. Nearly overnight, the workload in the molecular lab increased by over 90%. It's important to note that her department went from existing quietly in the background to being very visible and under the gun, to work harder, faster, stronger to deliver these COVID test turnaround times. And so it just speaks to the massive leaps COVID pushed us to make in service delivery, innovation, and experience, some of which is invisible to the public. So I think it's really clear that both the staff, patients, and family experience is of the utmost importance and worth dedicated attention. So how do we move forward with creating this vision of best care experiences created together? So I want to actually go back to Dr. Dalla. You're working to launch something called the Care Experience Institute, and we're all very excited for you to explain to us what this is, why it's mission critical, and how can we all support you in creating this vision?
Thanks, Dr. Marwaha. And I would stress that it's our vision. I think it's one that we share. And maybe it's easiest to see it if we talk about a patient. And I know it's hard to take our minds off the pandemic right now, and you can't have a talk like this without talking about the pandemic. But let's try for a few minutes, take ourselves out of the pandemic, go forward a few years, maybe to 2025. And imagine a patient, 70-year-old woman named Mariam Suleiman, a newcomer to Canada from the Ivory Coast, doesn't speak English. She's moved here after her husband died to be with her son and his family. And one day, while her son and his family are out of town, she's found wandering the streets by a neighbor. She's a bit confused. 911 is called. She comes to St. Michael's. But now it's 2025, not 2020. And en route to the hospital, the paramedics are able to communicate with the hospital electronically. And the staff here know, and so they have a French-speaking triage nurse waiting for her. She's seen by that nurse, and that nurse determines that actually the language barrier isn't the problem. We can't get an accurate history from Miriam because she's confused, not because she doesn't speak English. Miriam gets examined first by the nurse, then by the emergency department physician. She gets all of the usual tests. Her CAT scan of her head gets a preliminary read within 5 or 10 minutes, rather than the 3 hours it takes now, through an artificial intelligence algorithm that's been designed by Mohammed Mamdani's team. Fortunately for Miriam, there's no bleeding in her brain, no sign of her stroke, but obviously there's still something seriously wrong. The emergency department physician calls the internal medicine resident the story. Now, because Miriam is Black, and the senior resident knows that Black patients tend to have better health outcomes when they're cared for by Black nurses and Black doctors, the senior resident assigns Miriam's case to a junior resident who also is Black, named Monica. Today, Miriam probably wouldn't get cared for by a Black doctor. When Monica walks into the room, Miriam's face breaks into a smile. And even though Miriam is confused, her trust in Monica is obvious. Monica feels it. She starts to talk to Miriam. Can't get much history from her, so she pulls out her tablet. And she's able to get Miriam's son right there in the room immediately. He tries to translate too. They can't really get anywhere. Monica explains she's worried about a potentially fatal infection in the brain and that the way to make this diagnosis is through a lumbar puncture, a spinal tap. Miriam's son provides consent. Now, another change from 2020, Monica's done this lumbar puncture a dozen or more times in the simulation lab. And even though this is only her second time doing it on an actual patient, she's much more adept than residents would have been in years gone by. Residents like me who never learned how to do procedures through simulation. Monica completes the lumbar puncture. She orders the medication. She goes off to bed. Miriam sleeps through the night. First thing in the morning, her son gets a text message from the hospital asking for feedback on the care that's been provided so far, asking if either he or his mother has any questions, any additional needs. He's generally pretty happy with the care. He does have some questions. He inputs them into the system. And Monica gets them immediately when she wakes up. She's able to pass them on to the residents coming on. And he's able to be there at the bedside when Miriam's son is there to relay what is going on, to explain the diagnosis. In 2020, there would have been a series of messages back and forth via telephone, intermediaries, loss of information, confusion, uncertainty. Most of you have probably been there. I know I have. The treatment has started. It's working. Miriam spends a week in the hospital. She goes home, gets antivirals for another week at home. She has a near complete recovery. There's just a very subtle difference in her ability to find difficult words, do crosswords, things like that. But she thrives for many years to come. She loves spending time with her children and grandchildren. And she always has a soft spot for the people at St. Michael's who together with her son, helped create this great care experience. This is the kind of care that we hope the Care Experience Institute will make routine, not just at St. Michael's, but across the country. Miriam's story is actually adapted from that of a real patient, a patient who Dr. Marwaha and I actually took care of together just a few weeks ago. Obviously, some details have been changed and there's a futuristic element to it, but the core is actually the same. And in adapting the story, I tried to highlight a few areas that will be very different a few years from now. First, there'll be much greater use of digital communication and virtual care in 2025 than there is now. The pandemic has already obviously accelerated this. Most of you who have tuned in have probably had a virtual appointment with a doctor or another healthcare provider over the last 6 months. But there's a lot of work to do to make sure that the experience we are providing through virtual care is as good as, or actually even better than it used to be physically before the pandemic. Second, the care we provide in 2025 will be much more culturally sensitive than it is today. And again, the pandemic has thrown this really into high relief. The fact is, Black patients and Indigenous patients in particular, but not just Black patients and Indigenous patients, just don't get care that is as good as white patients, and they don't have the health outcomes that white people in Canada have. And I'm not saying race is the only factor. We also need to make sure people who don't have a home or people who use drugs get the best care experience when they come to St. Michael's. Third, artificial intelligence will allow physicians and others to make diagnoses more quickly, more accurately. We have a world-leading team here under Mohammed Mamdani, and we're already starting to see the impact of this at the bedside. Fourth, we'll be using simulation in 2025 much more than we do today. Again, an area where we are building on strengths at St. Michael's. Finally, and most importantly, and Dr. Snyder talked about this when she said we need to understand the journey better. We'll be collecting data in real time much more than we do now, and feeding that back to clinicians so we can provide the best possible care experience, learning as we go. The Care Experience Institute is at this point mostly a vision, but in 5 years, we'll have multiple centers focused on these issues and others. But we're going to need your help to make this happen, to recruit the innovators, the design thinkers, the researchers, to build out the space, and importantly, to provide support for the education that will really drive the change. But with your help, we know we can reinvent Canada's healthcare experience starting right here at St. Michael's. Thanks very much for listening to our shared vision for the future. And now I'm going to turn it back over to Seema.
Thank you so much, Dr. Dalla, Dr. Snyder. What a great discussion. I think this is the perfect time. We have a few minutes for the audience to weigh in on a few questions, and we're going to do our best to end right on time. So I'm going to go right to them. The first one, I think, is a good one for you, Dr. Dalla. So this question is from John. How optimistic are you that the 2025 scenario will become a reality and that this can be used beyond St. Mike's and across the country? I may cut you off, just a warning.
You can cut me off. I ramble. I'm an optimist by nature, but I think the optimism is borne out. You know, when you think about what we can do now compared to what we could do when, you know, even when I was in medical school or 10 or 15 years before that, I mean, it's incredible. Virtual technology is one example, but it's not the only one. The, you know, minimally invasive surgery, the new drugs, new diagnostic tests. You know, the pace of change is extraordinarily fast. You know, 5 years is a short timeline, and it might take a couple years longer. I don't know. I wouldn't commit to being able to do everything by 2025. But I also think it's important not to say these things are so far into the future. You know, there's a lot that we can change in 5 years. You know, Bill Gates, I think, likes to say that most people underestimate what they can do. Most people overestimate what they can do in 1 year and underestimate what they can do in 10. And I think we're victims of that in healthcare. You know, if we plan with a 5 to 10 year horizon, we can really change a lot. So great question. Thanks, John.
Thanks so much. Next one is for Carolyn. It's a specific, sort of Dr. Snyder, I should say. I'm so sorry. So where were the 20 people kept for isolation that you mentioned? This question is from Nazanin.
That's a great question. What the city did was they set up a number of different facilities. Some of them might have been various residences or hotels that weren't being used during the springtime of COVID to ensure that they could provide spaces where people would be in their own rooms and not sharing rooms, as well as access support. So they are actually all over the city at different spaces during the spring. Right now we just have one in the city, but we are hoping that there will be some expansion should we see the same kind of caseload as we did in the spring.
Thank you very much. I'm going to go fast so we can get through a few of these. So the next question, Dr. Dalla, is from Steve. This is an interesting one. What is the strategy for leveraging wearable tech to improve the patient experience and create efficiencies in hospitals? He gives the example of a Fitbit.
Yeah, absolutely. You know, it's a great question. I think we think about it more outside the hospital than inside the hospital, to be honest, but we are doing more of this inside the hospital. You know, and again, this is something that has changed in my career. The devices that we can use to be continually monitoring people's heart rate and rhythm, to continually monitor oxygen saturation, to feed that back into the nursing station. And actually, this hasn't happened to date, as far as I'm aware, at St. Michael's, but sometimes to feed it back to another physical site altogether. You know, certainly this has started to happen in the United States. It has both advantages and disadvantages because it's obviously good to have a human on site, but there are now intensive care units in the United States where the intensive care unit physician is in a different building altogether. And this is, I think, part of what we are talking about when we talk about collecting more information in real time so that we can continually improve the experience right then and there for the patients we care for.
That's fantastic answer. Thank you so much. I have a question for Dr. Snyder. What I'm interested in as well, what will you do differently in the emergency department in the second wave?
Thanks. That's a great question. Well, I think we did a lot right and we learned a lot around what we could do better. So there's no doubt that we hope to have in some ways a smoother experience. We're working very closely with the city and the shelters and Toronto Public Health to try and be out in front of this. One of the things we've done is we've launched specifically for those who experience homelessness, a dashboard that we worked with the DSSA team, AA team, so Mohammed Mamdani's AI team, to better help the workflow of all the people that are coming through, making sure we know who came from what shelter and where they're going. This also has provided us with an opportunity that whenever somebody like Tim or Tom Parker or Sonia Kanzian send me an email or give me a call and say, how many right now? Like, what's going on in the emerge? I can literally say, you know, we have 20 in our emerge right now that are waiting to be transferred to a isolation shelter. And the third thing is that we've worked with Toronto Public Health to ensure that our notification specifically for the shelter patients is getting out within 24 hours of a positive case so that those shelters know. Previously, it's been going through the same Toronto Public Health pathway, which is as you know, unfortunately still has a lot of work to do, and it can take a number of days before a positive case gets to them for contact tracing. It's a real problem. And so we're really trying to get out in front of that. And so at St. Mike's, we've actually made some big headway here. The second big area that we're working on is the development of a peer navigator program, and I did notice another question about that. We've been trying to develop a peer outreach program from the emergency department that would connect with the many community resources in the city. It was something that we identified as a need prior to COVID, and it became even more profoundly needed during COVID. The transition from our emergency department to community programs and outpatient appointments needs to be better. And we need to do that using a lot of the advice from our community members, those with lived experience. And so that's what we're working on right now. And we truly hope that we will be able to make this happen this fall, so that will help those who are affected by COVID as well. So the idea there is that the navigators would meet the patients in the emergency department through their experience in the emergency department, and then actually meet with them in the days after to help with warm handoffs and that transition to the community colleagues that can also provide care.
That's great, Dr. Snyder. And that's actually a great point, I think, to end on. I mean, I don't know where this hour went. I think this was a fantastic discussion, and we packed so much into this short hour. And we will do our best to answer all of the questions on the Q&A after this is over. But I just want to take it back now to Dr. Rutledge for some closing remarks.
Thank you very much, Seema. Well, folks, I have been really inspired by this conversation, and I think it's clear that we've got a big opportunity in front of us. And we're privileged to have the minds and talent to be able to reinvent how Canadians experience healthcare here at St. Mike's. Many thanks to you, Dr. Marwaha, for your expert facilitation of this inspiring discussion. Thank you to Dr. Dalla and Dr. Snyder for sharing your experiences, your expertise, and your inspiring vision of the future. And thanks to you and your teams, St. Mike's is already on track to lead the way in this important area. And finally, I want to thank each and every one of you for attending our online Powerhouse event and for your support of St. Michael's Hospital and our relentless efforts to tackle our toughest healthcare challenges. We wouldn't be able to do what we do without you. So once again, thank you to everyone, and have a wonderful afternoon.